これより基調講演感染症に残された課題を開演いたします。座長は京都大学理事副学長湊長弘先生です。それでは湊先生お願いいたします。
Okay, so we'll start a keynote lecture this morning. And our invited speaker this morning is Professor Barry Broom. And let me briefly introduce about him. And he has been the most influential leading immunologist, particularly in the field of infection immunity. I must say he still is. And he worked also pretty much in a public domain, and he has been former consultant to the White House, and also he had been involved in the vaccine sector in WHO. And he served as a dean of Harvard School of Public Health from 1998 to 2008 for 2 years, and he stepped out a couple of years ago. But still, he is involved in the education in the Harvard School of Public Health, as well as many public works, including Bill Gates Foundation management and so on and so forth. So we expect him to talk about general issues on infection, particularly in TB in the current world. Barry?
Konnichiwa. I'm enormously grateful for the invitation from Dr. Fukuhara Sensei to speak a bit about non-communicable diseases at what looks to be a wonderful meeting. And also, I was invited to speak about some of our work, which I hope you will find of interest. How do we get this? Okay. When I became dean, a school of public health can't do everything, so it was important to design a set of agendas or priorities, and these were those that we chose. And the first, because of my interest, is the unfinished agenda of infectious diseases. You've heard from Dr. Klog about the coming epidemic. It's actually a present epidemic of chronic diseases. We see an unnecessary epidemic of violence, injuries, substance abuse, terrorism, and disasters. The environmental risks to health with pollution. A major problem globally everywhere is disparities, as we've heard this morning, even within Japan. And finally, the issue of health systems, which I will try to emphasize. If we look at the global burden of disease, the years of healthy life lost through premature death or disability, the bottom line is very simple. 86% of premature death and disability occur in the poorest countries of the world. If we look at where money for health goes in the world, we see that only 16% of global expenditures in health actually go to the poorest countries. That's a fundamental inequality and inequity that has, as you will see and know, serious consequences. As Dr. Klog pointed out, the increase in morbidity and mortality is happening in the industrialized world in non-communicable diseases. But we cannot forget that in the poorest countries, in Southeast Asia and the African regions of WHO, the major burden remains communicable diseases, particularly HIV and its associated co-epidemic of tuberculosis. The burden of infectious diseases is about 15 million people die. About a quarter of all deaths in the world are attributable to infectious diseases. And as you can see, the major causes are respiratory infections and HIV, AIDS, diarrheal diseases, TB, vaccine, preventable diseases that are not being prevented, malaria, STDs, and others. At the same time, there is an increase illustrated here in antimicrobial resistance. In blue, we have MRSA. In black, we have vancomycin-resistant enterococci. And in the bottom is fluoroquinolone-resistant Pseudomonas. And as we look at the emergence of antibiotic resistance on the right, we see that there's been a decrease in interest in the pharmaceutical industry to create new drugs for antimicrobial activity, a very serious global problem. Clearly, there is a problem that you know very well of emerging and re-emerging infectious diseases, whether it is HIV or cholera or yellow fever or dengue or what has preoccupied the world in the last year, Ebola. And I'll say a few words about Ebola and look forward very much to Dr. Piatt's talk, which I hope will give us some understanding in detail. Winston Churchill once said, "Never let a good crisis go to waste." Ebola is not a good crisis. It's a disaster with 25,000 cases and over 10,000 deaths. And the question that we need to think about is, what can we learn from Ebola, its failures and its successes? So let me just set a context, which I think is a different framework than in infectious diseases that we commonly think about at the moment in non-communicable diseases. The entire budget, the entire GDP of Liberia is less than $2 billion a year. Compare that with that of Japan, which is $5 trillion, in the United States, almost $17 trillion. These three countries are very, very poor. If you say maybe they didn't spend enough money on health and their health care, the country that spends the highest on GDP per capita in the world is my country, the United States. 17% of our GDP is in healthcare, and it turns out Liberia is number 2. It is not that they didn't spend money on health, it's that they didn't have money to spend on health. If you ask the question, what is the availability of health personnel in these three poor countries, you can see for a population of almost 20 million people in Liberia with 4 million people, before the outbreak, there were 51 doctors in the country and fewer than 1,000 nurses. How could that possibly enable them to deal with an epidemic of Ebola? So the question is, how could this have happened? And a major theme of my talk will be the global and national health systems failed. The World Health Organization failed, and I won't spend too much time on it. I've spent a lot of time thinking about it. I've worked at WHO since 1966, about 45 years in some capacity. An example, in December there was the first case, probably in Guinea, of Ebola. In March, Médecins Sans Frontières notified WHO that it was facing an epidemic never seen before. Within a few days, the head of communications at WHO said not to worry, don't get excited about an outbreak with sporadic cases of limited geographic areas. That was a very poor judgment. In July, the general director of Médecins Sans Frontières is quoted in the press as saying, WHO should have been fighting the virus, not Médecins Sans Frontières. And 4 months after the MSF letter, WHO finally responded to call Ebola as a global health crisis. And their first meeting on Ebola dealt with ethics of use of drugs and vaccines that did not exist at the time. Misplaced priorities, in my view. Now, one of the ways to understand how organizations work or fail is always to look at the budget. And this is the budget planning for the 2014-15 biennium at WHO. And I would ask you simply to look at what happened to the budget for outbreak and crisis response. There was a 50% cut, the biggest single cut in dollars of any program within WHO. This was not a great decision either. If WHO failed, then the country's systems failed. We know that doctors fled, hospitals closed, there were very few isolation facilities, almost no lab capacity to diagnose Ebola. People were dying of probably more conditions that weren't being treated than died of Ebola during this time. There was a very poor information and surveillance system, so the countries and the world didn't know what was happening. There was a challenge of culture in the burial practices, and the ultimate failure is probably the source of its ultimate success, as Ebola has dropped. The early failure to engage the communities and the heroism of the communities responding to getting things right. The international health community, what this organization is a representative of, also failed. I remind you that in 2005, 194 countries signed a treaty obligation called the International Health Regulations to strengthen health systems in very specific ways to protect the people and those of their own and other countries against epidemic crises, primarily in this context, and inevitable influenza epidemic. It is tragic, in my view, that aid was either not sought, and we met with ambassadors to the United States from 10 West African countries, and when asked how did they request assistance to strengthen health systems, there was silence. Nor was there aid forthcoming from the rich countries who knew, with the resources available, these countries were not equipped in their health systems to deal with epidemics. There's a very wonderful faculty member at our school, in the medical school, named Donald Berwick. He was appointed by President Obama to help design the Affordable Care Act for healthcare. And this is a profound statement. It says that the basic principle of systems is that every system is perfectly designed to achieve the results it achieves. If you want greater levels of achievement, you've got to change the system, not tinker at the margins. Not all change is improvement, but all improvement is change. And the theme of this part of the talk is that the global health system really needs to change. The global health system for infectious diseases clearly needs reform and coordination. So the good news and the bad news on HIV is, if you look at this curve from UNAIDS, which Dr. Piot was heroic in leading for many years, the curve is bent down and the numbers are coming down. The bad news is, from the point of view of a finance minister, the number of people living with AIDS continues to rise, and each of those requires antiretroviral therapy, which costs a great deal of money. But the good news is the curve is coming down. In the case of malaria, with bed nets and artemisinin combination therapy, malaria is dropping precipitously in many countries. And yet, we know that resistance is rapidly increasing for all the old drugs within even quicker periods of time. And now the newest drug, the only good drug we have for malaria, is developing resistance. I was grateful to Dr. Fukuhara for allowing me to talk about what I work on and what I worry about, which is this prize-winning picture of a colleague of mine, Ann Goldfeld, dealing with a woman who died 24 hours after the picture was taken of tuberculosis, and you can see why it was called consumption. There are 9 million new cases a year. There are 1.5 million deaths. It's the cause of about 1/3 of all the deaths in Africa from HIV. There's about 485,000 cases reported in 127 countries of multiple drug-resistant TB, some of it completely non-treatable, and that may be only 1/10 because there's so few laboratory facilities to measure drug resistance. And the percentage of culture-positive patients even screened for drug resistance is 7%. The major risk for acquiring tuberculosis is simply breathing. In terms of tools, we have no vaccine that is very effective. We have no point-of-care diagnostic or drug sensitivity test. No single effective drug regimen for both drug-resistant and drug-susceptible disease, and the second-line drugs for resistant TB are awful, terrible, and the default rate of patients is about 25%. They would rather die than suffer the medications. In terms of what we need to have for better tools, new drug targets, but there's little interest in the pharmaceutical industry. We need well-defined clinical populations where we could test new tools, and we simply do not have an understanding of the necessary and sufficient conditions of immune protection, molecular correlates or biomarkers of protection. The key to TB control, as you all know very well, is to find people with the disease early case detection, directly observe treatment until they finish treatment, and initiate treatment as quickly as possible, and then complete treatment in 6 to 9 months, or for MDR-TB for 2 years. That requires a functional TB health system, which is basically not present in most poor countries. So if you look at the WHO DOT strategy, it has done remarkable things. It has probably saved 45 million lives in its origins since the 1990s. The prevalence of TB is declining, but not nearly where it should be. And the incidence is declining at most about 1% a year. It will never reach the Millennium Goals by 2015 or even 2050. The burden is really focused on 22 countries, including India and China, but many sub-Saharan African and Asian countries. And drug resistance is present in essentially every country of the world. The problem right now is that even if we had an effective drug regimen, a combination that really works on drug-susceptible and drug-resistant TB, or a very good vaccine, we do not have a system that could get it to the people who need it. So TB is not only an infectious disease problem, it's a health systems problem. The cost of treating TB is one of the great bargains, the best buys from the World Bank's perspective of any health condition, $20 to $100 per case cured. But with MDR-TB, it's about $5,000 per case cured, which is more than the TB health budget in about 20 countries. More importantly, in a way, is MDR-TB is a major threat to hospital personnel. How many of you would want to volunteer to work in a TB hospital treating MDR-TB patients for which we do not have good second-line drugs? The major risk, as I said, is breathing. It's spread by aerosol. 90% of the people infected will never develop tuberculosis. Those who are infected have only a lifetime lifetime risk of 10% of developing TB, although if they have HIV, that becomes an annual risk of almost 10% a year. But this tells us that the immune system has to be important for protection against TB. From a clinical point of view, the decision on whether a person with a cough, a fever, weight loss for over 3 weeks is a binary decision. Either they have TB or they don't have TB. From a scientific point of view, TB is a spectrum. There are people who are resistant, who are exposed, resistant, and never become tuberculin positive. How is that possible? We assume that that's innate immunity. There are people, the 90% who we know are infected, that do not get disease, have latent TB, and we presume acquired and innate immunity are protecting them. There are then people with active disease, pulmonary and extrapulmonary TB, but only those with pulmonary are a problem for transmission. And that says there are multiple points that we could combat the disease. If we had a good vaccine, we could prevent infection. If we had good drugs and good diagnostics, we could prevent latency from being established. Or importantly, we could find people who are tuberculin positive and predict and prevent them from progressing to active disease. And finally, the ultimate goal of any infectious disease is to cure the disease, to reduce transmission. That's the number one goal of eliminating an infection disease. So the questions that we began to work on, because 90% of people with TB do not get disease, have been some very simple immunologic questions. What are the necessary conditions for protection? And what are the sufficient conditions for protection? What are the roles of innate and acquired immunity? How do you activate macrophages in which the bacillus resides to kill the bug? And in the course of killing the bug, is it inevitable that we get tissue damage which leads to lung damage, which is the vehicle by which TB is propagated and transmitted? And it's a slow disease. Are there molecular markers that would tell us whether we have a drug or vaccine that's working? Those are the questions we and others have been involved in. So in early work, we looked using mouse models, which were very easy, for mice that had genetic knockouts in important genes. So in mice that were knocked out for interferon gamma, in the blue, they die and they die very quickly. We assumed if we knocked out tumor necrosis factor, we would diminish pathology, but what we diminished is resistance. So TNF, like gamma interferon, is absolutely essential for protection, at least in mice, and killer cells restricted by MHC class 1 are also necessary for protection. But as things stand now, none of those is sufficient to guarantee protection. For work on humans, I have collaborated for 30 years with my friend Robert Maudlin, and we asked a couple questions. My lab had shown that in the mouse, the way macrophages kill TB is by producing non-oxygen radicals, to which MTB has become very, very resistant. But nitrogen radicals, nitric oxide. And the first question is that how human macrophages kill TB, and can we augment that? And the second is, rather than skin testing and rather crude tests, are there molecular tests that would predict what we have to do to generate protection against disease? So the hypothesis is that we breathe in, when we get infected with TB, a very small number of bacilli. Between 5 bacilli and maybe 400 is enough to cause disease. In most people, we assume innate immunity is sufficient to kill those, so we've all probably been exposed, but most of us have killed it before it grows enough to generate a tuberculin skin test. But once it does, then we need T-cell expansion and acquired immunity to develop a protective response. But that cell-mediated immune response is also contributing to the damage in the lung that assures TB will be transmitted. What do we know about innate immunity? It's a very recent area in immunology. And what we know is, like most of immunology, it's complicated, but that there are many receptors on cells of the innate immune system that recognize repeating patterns of carbohydrates or lipids in a wide variety of organisms. And when they are activated, they lead to increased phagocytosis, antimicrobial activity on the good part. They enhance acquired immune responses, or in the case of toxic shock and autoimmunity, they actually contribute to tissue damage and disease. This does not require any immunization. If we then ask the question, do human macrophages kill TB bacilli the same way we studied in mice for 20 years? The answer is, to our enormous surprise, they do not. If we add an inhibitor, if we add a stimulus of the toll innate response, we have in the second column an ability to kill the organism and reduce colony-forming units. We can reverse that in mice with an inhibitor of nitric oxide synthase. We cannot reverse that in the case of humans. Therefore, what is a mechanism in mice is not proving, has not been found in many laboratories to be a mechanism in humans. So the question is, what is the mechanism or a mechanism in humans? And so a graduate student, Philip Liu at UCLA, did a very simple experiment. He looked at gene expression profiles of dendritic cells derived from a blood precursor that is an antigen-presenting cell to B and T cells versus macrophages, which derives from a similar precursor in blood that kills intracellular bacteria. And when stimulated by the innate receptor, only one major gene showed up in the gene profile in red on the left, and that is the vitamin D receptor. I received a phone call on a Saturday morning that said, "Dr. Bloom, what do you know about vitamin D and tuberculosis?" And the answer was nothing. And so we had a research project to learn. So we looked in what is known about the genetic and biochemical pathways that vitamin D is involved in, where a precursor, 25-vitamin D, is converted through an enzyme into the active form that binds to the vitamin D receptor in all cells, but in immune cells produces an antimicrobial peptide called cathelicidin, which we had never heard of before. When that peptide, it's only 37 amino acids, is added to tubercle bacilli in a test tube, it kills them. The vacuole containing mycobacteria in cells prevents other molecules from entering. But if we label the organism, in this case BCG, label cathelicidin with an antibody, we can show that the antimicrobial peptide gets into the vacuole containing the tubercle bacillus. So why are we interested in vitamin D? What is its public health significance? Vitamin D is made by UV light when it shines on the skin, produces vitamin D, 25 hydroxyvitamin D, found in the blood, and that is converted in macrophages in liver into the active form. And this is why we were most intrigued by this observation. We know that African Americans, from historical purposes, are much more susceptible to TB than whites. We know that a disproportionately large amount of TB cases in the US are among blacks, 8 times more than whites. And we know that dark-skinned people, not just from Africa, but even from India, have a more severe course of disease. And we also know that African Americans who have melanin, which is designed to screen out UV light, prevents the sun from generating enough vitamin D. So if we look at the ability of serum and look at the concentrations on the left of levels of vitamin D, serum from normal black people have about 1/4 the amount of vitamin D than from white people. If we ask whether their serum will support the production of the antimicrobial peptide or its RNA, the answer is they are highly deficient in producing the antimicrobial molecule. But if we add vitamin D to that serum, we can reconstitute the microbicidal response. So we think we've learned something in humans that we didn't know before. Where does the field need to go? I think the field needs to take advantage of what is a new phenomenon or a new aspect of science, putting many things together with big data and information called systems biology, and an analysis of, can we get molecular markers to tell us who is going to progress the disease and who is going to be protected. And this is work from Ann O'Gara's lab in London that we found very interesting. These are gene expression profiles of people, either on the left, healthy in the first column, or shortly after diagnosis with tuberculosis, and then after 2 months and 12 months of treatment. As you can see, there's a whole lot of genes that go up that are not present in normals, but go up in people with TB. And in the right-hand side, when they're linked into pathways, the vast majority of those genes are induced by interferon, primarily type 1 or interferon beta. And to simply save time, we can simply say that that type 1 signature is not a correlate of protection. It's a correlate of pathogenesis. So we have worked out the entire pathway between innate immunity stimulated by the toll receptors, acquired immunity stimulated by T cells and gamma interferon, through this whole complicated pathway to make antimicrobial peptides that kill intracellular pathogens. But we have also worked out that that entire pathway is blocked by interferon beta through a molecule called interleukin-10, which is involved in tissue damage, and that leads to pathogenesis. And resistance or pathogenesis in TB is a subtle balance between those two and probably many other factors. What we have learned, I would like to believe, is some important lessons. First, that animal models often do not predict human immune mechanisms, and that implies an urgency for translational research, study in humans. Our studies with human macrophages indicate that killing of TB is vitamin D dependent, mediated by peptides, not oxygen radicals or nitrogen radicals, that these two immune mechanisms, innate immunity and acquired immunity, that evolved over time and evolution entirely independently, have evolved a common microbicidal activity that exists in humans, that dark-skinned people make less vitamin D, and hence that may explain their susceptibility to TB and other bacterial infections. And finally, type 1 interferons, which we think is a good thing in fighting viral diseases. We've shown that it can suppress antimicrobial responses against bacterial infection. Where are we now? We have a big problem and a very small tool. Arigatou gozaimashita.
Okay, thank you, Barry, for a very extensive speech. And I think we can take a brief question or two from the floor, if there is. Barry, I have a brief question. What happened about the recent attempts to produce effective TB vaccines overall? Do you have any new advances on that?
Say it again.
TB vaccines.
Oh, TB vaccines, yes, TB vaccines. The reason we focus on the questions of what are the necessary conditions, but more importantly, what are the sufficient conditions, is we have no way now, in my view, in experimental animals or in laboratory tests to predict what pattern of T-cell responses and cytokines and gene expression will predict protection. So there has been one new trial of a vaccine sponsored by the Gates Foundation, carried out in Oxford, in a very interesting viral vector called modified Vaccinia oncara with a protein from TB. It was given to 3,000 children. It produced no protection against infection and no protection against disease, and it cost tens of millions of dollars. So we are faced with the challenge that until we have better scientific measures of protection, we shouldn't be wasting vast amounts of money in large clinical trials of arbitrary vaccines.
Okay, yes.
Deficient in vitamin D, is there evidence that vitamin D supplementation enhances the response to anti-tuberculous therapy?
A wonderful question. Thank you for that question. So if vitamin D costs perhaps 1 penny a day to give to anybody, I take 2,000 units a day just to be safe. There has really not been a serious randomized control trial of vitamin D, probably because for a medication that costs 1/10 of a cent a day, there is zero interest in the pharmaceutical industry or even the NIH in paying for a real clinical trial, which is not so easy to do, best to do in dark-skinned people, perhaps in Africa. There's a recent report indicating that vitamin D seems to correlate with protection as well against HIV. So this is a trial that would cost very little in terms of drug and could provide a lot of information on how to increase innate immunity, which we've shown, and perhaps potentiate acquired immunity as well. And no one wants to pay for it.
Yes, in the center of the floor.
Amanda Howe. I'm a family medicine academic from the United Kingdom talking in the primary care session this afternoon. As a family medicine doctor, I'm always very interested in the application of the science into the clinical setting. And so I would like to take you back in your very interesting talk, for which many thanks, to the first part where you were talking about how good we are at delivering new findings in the healthcare systems. And I'm particularly interested for this audience in the comments on how much research is done about the delivery of new science in the healthcare system. Because even if this track of thought around vitamin D proves profitable for health, still we have the problem from the first half of your talk about will the people who really need it actually get it? And to me, it seems that the research funding often doesn't go into the delivery system side of science.
Thank you so much for your question. It's a wonderful question. I think you're quite right that there's an enormous amount spent on fundamental science and much less in how to use that science to reach people in many countries, but particularly in the poorest countries. You will hear from Professor Rifat Atun later today, who has, in a way, been heroic in studying systems as an academic, but also implementing them to create a functional health system in a country, a middle-income country, that didn't have it, as well as advising many others. But for the poorest countries, I would suggest that we have a lesson to be learned from the little country of Rwanda, which has very little more per capita income than the 3 countries with Ebola, but has set up a primary health system after 14 years of civil war where there was no health system, and has a very, very effective system, including for HIV and TB, but it is stratified in a very different way than we think about it. It's not built around doctors and hospitals. It's built about community health workers, supply chains, information technology, and it seems to be working very effectively. And one would hope, with support from the international community, that model could be applied to the West African countries as well.
Okay. Yeah, over there.
Thank you for a fascinating talk. Could I ask, given the limited dollars available for research, would you rather spend your funds in prevention on a vaccine or the development of drugs to treat established disease?
The answer, of course, is to spend money on both. Our field suffered a huge loss. When the Global Fund was created, it was called the Global Fund for, the Millennium Development Goals were created. The 6th goal was to reduce AIDS, malaria, and other diseases. And we were an other disease and pretty much ignored or diminished in the funding. The answer is both will be difficult, and if I were in charge of investing, I would push very hard on both fronts. The first is to find regimens that work on drug-resistant as well as drug-susceptible TB that eliminates the need for expensive drug sensitivity testing as long as those drugs remain efficient. But my strong view is until we have a vaccine to prevent the disease, we will not put the disease into elimination or full control anywhere.
Okay, maybe the final question.
There have been huge numbers of the scientific papers reporting the immune response in mice. However, as you mentioned, that we are now getting more and more aware that there is some discrepancy or inconsistency between the human response and the mouse response. So do you think now we have to go back to some different animal models, including the guinea pigs or rabbits, because the long time they produced a very good the diseases like which is similar to the human response. What do you think?
I have spent my career looking at animal models, and as I told Dr. Minato, I closed my lab not because we didn't have grant money, but I thought the returns from the animals were at this point somewhat misleading rather than helpful in thinking about human disease. So directly to answer your question, I would say 2 things. Each animal model has certain advantages. The rabbit has the closest pathology. The guinea pigs have the greatest susceptibility. Mice are highly resistant. It takes a lot of TB to kill a mouse. We can learn something from each of those. But the real question is, how do we predict what will work in humans? And I think the emphasis now, I was privileged to chair a review committee for the Gates Foundation, and one of the recommendations is a great deal more work in non-human primates as the closest model to studying humans, where we can look at local responses in the lung that we cannot study easily in humans. And secondly, as I indicated, we need to do lots more intervention translational research on humans, volunteers and patients, if we really want to understand the necessary and sufficient conditions. Before I step down, I have to say one more thing. You know, there's nothing that is more rewarding for a teacher than to have a student succeed. I cannot tell you how thrilled I am that my first postdoc from Japan, Dr. Nagahiro Minato, became dean of Kyodai and is now vice president of Kyoto University, an august institution, and I am just beaming with pride, and thank you for allowing me to come.
Okay. Thank you very much for the very extensive talk, and I'm very glad to hear that Barry is still working on this cutting-edge science in immunology. Okay, thank you very much. This will end this session. Thank you.